So in our first section, we will talk about in-office prevention. And we want to specifically focus on, at the beginning of this, the use of fluorides in the dental office. We're going to talk a lot about fluoride varnish. So fluoride varnish is a very useful tool to prevent disease. We use exclusively varnish at Sparks. You won't see us using gels or foams or anything that we have to actually put in a tray, because most of our patients couldn't tolerate having a tray in their mouth for 4 minutes. Now, you may see some people in some offices wanting to just brush on a foam or brush on a gel, but there's really no evidence that that's actually effective. You really need that foam or gel to be able to sit in place for at least 4 minutes for it to really do a good job preventing. And that's not often a real expectation in our clinic. So we exclusively use fluoride varnishes. We find that we have less gag reflex issues than what we would get with trays, and it's tolerated better, but it also has the advantage of being a stronger fluoride that's applied directly to the surfaces that we're really wanting to do the most prevention on. We find that we can apply it very quickly. We take a brush and just quickly go in and apply it to all the surfaces. The saliva actually helps it congeal and stick to the teeth. And once it's stuck, then it's going to be there for a fairly extended period. So with a foam or a gel, you may get 3 or 4 minutes of good contact, and then it begins to quickly kind of be washed away. With a varnish, it's going to stick on the surfaces for a while and create a reservoir of fluoride going through the mouth and bathing other tooth surfaces. A real advantage of fluoride varnish is that there's no waiting period after you place it. If you've had a foam or a gel, you're probably used to being told not to eat or drink anything for 30 minutes or 20 minutes or something like that after you've had the application. Fluoride varnishes, you don't really have that limitation. You eat and drink almost immediately. In fact, there are times that we'll even, with a patient with a particularly sensitive gag reflex, we may rinse the extra out. So fluoride varnishes are the preventive tool that we use in office almost exclusively, but they're not simply tools that were only used for preventing new lesions from developing. Very powerful in preventing new lesions, but they also can prevent existing lesions from getting bigger. Okay, so they can prevent new lesions from forming. We all think about that. But I want to spend a few slides showing you evidence that they can prevent existing lesions we've diagnosed, from getting bigger. So in 2018, the ADA published the article that you see on your screen right now. It is their clinical guideline on non-restorative treatment for carious lesions. Okay, notice this is, again, not saying healthy tooth surface or preventing carious lesions. These are diagnosed carious lesions, and how can we treat these without having to go in and do restorative care? So the first category that the ADA recommended we look at was non-cavitated occlusal caries. Now, occlusal caries is probably the most common caries that you will treat as a dentist. You'll see more of it than any other type, and it's true in our special needs populations as well. So if I can prevent having to go in and restore a lot of occlusal lesions, then that's been a really big help. And they looked at a lot of different ways of going about preventing occlusal lesions from getting bigger. And the method that they found that was the most effective was to combine placing a sealant over the caries. So we haven't gone and cut it out. We're just placing a sealant directly over the caries, and then applying fluoride varnish at 3 to 6 month intervals. Okay, you see this applied every 3 to 6 months. Okay, that this was strong evidence that this combination would prevent occlusal lesions from progressing 67 times out of 100. That's impressive. Okay, this means that almost 2/3 of the time, this would keep me from having to figure out how to get a burr into a patient's mouth. Now, in a typically developed patient that I can easily go in and place this restoration, maybe that's not such a big deal. But in my young pediatric population and in my special needs population, preventing having to go in and cut can be a very positive thing. 67 out of 100 times, if I can prevent having to go forward, boy, that's a win. Now, some of my patients placing the sealant is not real. And the ADA also showed in this article, I don't have it on screen, but it shows in this article that just placing the fluoride varnish alone prevented almost 50 out of 100. It was in the 40s, 40 out of 100 times. I could prevent having to cut the tooth just by placing fluoride varnish. And I consider that a win as well. Now, in this slide, we're talking about aproximal surfaces. We're talking about cavities that are developing in between the teeth. These may be on bite wing x-rays that we would have picked this up and we would see shadowing interproximally. Placing fluoride varnish at regular 3 to 6 month intervals showed a 2 times greater chance of reversing or stopping progression of those interproximal lesions. So it was almost 50% of the time, 46 out of 100 times, it would prevent those small interproximal lesions from going forward. And they found this to be a very simple and cost-effective tool for preventing aproximal surfaces from moving forward. If we look at class 5s, so now we're looking at facial or lingual surfaces, so class 5 type restorations, then they actually found that fluoride varnish or fluoride gel would be effective in preventing those. So, again, for simplicity's sake, we're sticking with our fluoride varnish. Now, in my special needs population, root caries becomes an issue. And so we definitely have times that patients are needing to we're trying to prevent root caries for progressing. And so the ADA recommended that this product, Preventive 5000, be used at home for daily home care. And we'll talk more about this later in the lecture, but this is a high concentration fluoride toothpaste that can be prescribed to a patient to apply. And again, we'll talk about it more in the later part of the lecture. But in this situation, just note that it was a valuable tool in preventing root caries from progressing. Now, what happens if we've got a lesion that's too big to just try to prevent its progression and I need to actually restore it? With special needs populations, I want to be thinking about how can I restore with materials that will prevent future cavities from developing. Okay, so how do I not only restore the hole, but prevent other cavities? When cavitation does occur, then we are going to be looking at an array of different options. If it's not too big or if behavior is too difficult, then using silver diamine fluoride, you will see done a lot in at Sparks, where we are just simply trying to arrest the lesion. It turns it black, but it may prevent it from getting any larger. Small lesions, areas that would be very difficult for a patient to tolerate, this becomes a very good option. Resin modified glass ionomers, and you see Fuji 2LC on your screen, but Fuji 9 is another product. Ketac Nano would be another product. But any of the resin modified glass ionomers can be very nice choices to restore small, moderate size cavities that are in a patient that is not going to be able to tolerate a more traditional type of restoration. And the advantage of these is, of course, they're releasing fluoride so that they're helping not only fill the hole, but strengthen the surrounding tooth. If it's too large for this sort of option, then stainless steel crowns become a excellent option that we use. And we use these a lot on permanent teeth as well. So not just baby teeth, but we have them for permanent teeth, so that they cover not simply where the hole was, but the remainder of the tooth to protect it. So if I'm trying to prevent do in-office prevention of caries, fluoride varnishes are our number one tool, and then silver diamine fluoride, glass ionomer resins, resin modified glass ionomers, and stainless steel crowns become very good options for restoring the actual cavity. Now, what am I going to do to help prevent the most common type of issue that we will see in the special needs population? And that is, how am I going to handle in-office prevention of periodontal disease? So calculus control becomes one of the biggest issues that I face with periodontal disease. Now, when I'm dealing with young pediatric patients, very often their tissue will be very healthy. In this patient, you can see wonderful gingival margins, nice spacing. Really, in this type of patient, I'm just not going to expect to see a lot of calculus. But in my special needs population, very often they're going to look in their mouths and we're going to have a lot of staining and a lot of calculus. And here you see traditional manifestations of it on the lingual of the lower incisors, where it has a tendency for most people to accumulate. But I want to show you here, this is a good example of the type of thing we see at Sparks a lot, where the patient may come in and really you don't see visible calculus, do you? This right here, if we touched this, come up here, touch that, there, that's probably soft plaque, not calculus. But look at the tissue and see how swollen the tissue is. When you see that type of swelling, almost always there's going to be calculus underneath the margin. And a lot of times it'll manifest as a circular ring of calculus that's just underneath the tissue. And if you don't go underneath the tissue, you'll never realize it was there. In fact, we had that happen this week. A patient that had been marked from previous visits as not having calculus. We were suspicious. In fact, we talked about it even before the patient came in. I bet you we need to look because this patient probably has calculus. And when they came in, the tissue looked a lot like you see on your screen. We explored up underneath the tissue margin. And yes, there was extensive calculus and actually periodontal disease that was going on that had not been adequately treated in prior visits. So when you see this type of tissue manifestation, make certain that you check under the margins for the presence of calculus that's not necessarily clinically visible. Now, when we see the calculus and it's super gingival, okay, so we're able to notice that clinically there is calculus present, then I'm going to typically use a sickle scaler. I'm going to use the pointed end of that sickle scaler to go interproximally, and I'm going to slide up the tooth. I'll use that to go down in to get the calculus, gently lift up. Okay, so here you can see it going into the tooth, and you see me lifting up. With this instrument, I'm going right to the tissue surface and lifting to remove it. See that going again. Okay, so going to the margin of the tissue, staying supragingival with that instrument, and removing supragingival calculus. But how am I going to handle the subgingival calculus? Well, here I'm going to use a curette. The curette has the rounded end. So you can see here on my instrument, you see the rounded end. Okay, I'm going to take that, I'm going to slide it below the tissue and gently lift up. Okay, let that run again. There we go. Okay, so we're sliding below the tissue, pushing against the tissue with the very toe of the instrument, and lifting up. Okay, I'm going to try to replay that. To see if it won't be quite as jumbled there. Okay, so we're going to go into the tissue, use the toe of the instrument, and gently pull up. Okay, going underneath the tissue as far down as I can push and lifting up. Again, use the toe of the instrument to slide up. Now, when you first go in, you're going to slide down and you're going to feel, do you feel anything that feels soft? It's kind of an exploratory move that you're going down and seeing what you can feel. Then when you feel it, engage it with the toe and take it out as you lift up, keeping pressure against the tooth. Now, one of the things that you will see that's unique in this population is you may actually see calculus manifesting on the front of the teeth, in front of the lower incisors instead of the lingual. And what's going on there is very often when the patient goes to brush, they will tighten their lip very tight and keep the toothbrush from being able to access that area of their tooth. So you can see that here, a tight lip and the toothbrush can't get down. And so in that situation, then this area doesn't get brushed, food gets pressed against it, and you wind up with this type of calculus buildup. Okay, so this actually becomes more of an at-home solution, but when you see that, you'll need to teach the caregiver how to pull the lower lip down so that they can get all the way down to the gingival margin, show them how to pull it out. And you'll have to do the same thing. You'll have to really work to pull that away. For you, you may have to place your finger where the lower lip and the buccal mucosa join. So you'll be inside the lip and put your finger all the way at the floor and then kind of roll the lip out. And with some of our patients, that can be very challenging. They've got very strong lips and you may have to really pull, but putting that finger all the way down to the very bottom of the lip will help you tease that mouth open and tease the lip out. Now, when it comes to plaque removal, here you're seeing the rubber cup and the proper use of it. And what I want you to notice is how the rubber cup is getting all the way to the gum line and actually going underneath the gum line, okay? We're not just getting up at the occlusal third. Remember that the tooth is contoured and it actually curves in toward the gum line, so you're gonna have to roll that in. I'm gonna play that again and see if we can get that to not be quite as jumbled in the recording. Notice again how I'm getting all the way down to the gum line and I'm following the contour of the tooth to make sure that my rubber cup goes just below the gum. I'm not staying in one location super long periods of time, but also notice that I'm letting the spin of the toothbrush do the work. I'm not using this like a toothbrush where I'm brushing back and forth, but I'm allowing the spin of the toothbrush to clean the plaque and the staining off of the teeth. Here, I want you to notice that I am actually rolling interproximally. Okay, so we're actually going to roll interproximally with the toothbrush to get in between the teeth. I mean, with the prophy cup, trying to get in between the teeth. You can really see it on that lateral incisor, and there on the central too. I guess you can see that we're rolling in between. Now, for some gag-sensitive patients, actually being able to do the rubber cup in one continuous motion can be overwhelming to them. And so what this slide is going to show you is the technique of sort of doing the rubber cup in pulses. Okay, so you'll see that I go onto the tooth and come off. Go onto the tooth, clean for a second, and come off. There you go. That showed it a little bit better. I apologize that the video seems to be wanting to jumble when it's playing here. Which I think you can get the scene. This becomes most critical very often down around the tongue. We go in, touch it, let it clean for a second, let the brush spin, and then come back off. Okay. Now, patients that have that are gastrointestinal tube fed, those patients will very often have very heavy calculus and can be very, very hypersensitive and hypersensitive gag reflexes. So those can be challenging. We had one of those yesterday in the clinic that we needed to actually leave. We left completely sitting up at a 90-degree angle and even had someone holding the head and tipping the head forward so that water was not going to the back of the throat as much, but coming forward. But when we clean those patients, we typically remove from the buccal and lingual, and we leave the occlusal calculus. So we get it off the buccal and lingual, but leave it on the occlusal surface. So these patients, typically we're not going to necessarily think of 6-month recalls. We have a lot of our patients that are on 6 months, but we have a number of them that are on 3 and 4 months. The G-tube patient fed, G-tube fed patient that I mentioned a second ago, we see that patient on a 4-month interval. I even have one patient that comes every month to us. This does become a little bit of a problem because a lot of third-party payers will not pay more than twice a year. So if you're going to put them on a more frequent recall, you have to make sure the family understands they're going to end up getting paid. They're going to end up having to pay for some of this themselves if they have insurance, and make sure that they're okay with that. And if they're not, that's their choice, but our recommendation would still be to come in more often. I can minimize my cost if their insurance isn't going to pay for it by only charging for the cleaning. I would need to do an official exam more frequently, so I don't have to bill for that. And I wouldn't necessarily apply fluoride more frequently, so I may just do the prophy and not bill the other things. So that's an overview of what we will do, an overview for what we will do with in-office prevention. And in the next section, we'll talk about things that can be done at home to help prevent disease at home. So we'll see you in the next section.